Okay, so welcome to week 6, Rheumatology and Musculoskeletal System. Apologies that I've had to put this online. My 2-year-old has unfortunately had quite a nasty accident in daycare and has smashed a number of his teeth. So we needed to have an emergency dental appointment. So again, I'm sorry about that. It was unavoidable. Okay, so some objectives for this lecture. So a brief introduction to autoimmune diseases with some emphasis on rheumatoid arthritis, rheumatic fever, and lupus or systemic lupus erythematosa. We go over some non-traumatic injuries in the musculoskeletal system. All of the traumatic stuff you'll cover in 337, but we go over the stuff that is non-traumatic. Have a little bit of a look at the anatomy and physiology of the musculoskeletal system, especially with the disease processes that we're looking at, and some out-of-hospital management of the above care. Okay, sorry, I'm going to have to pause. The baby is crying. You right, babe? Okay. All right, so I'm just going to keep going. I apologise for the crying. But a very unhappy young man. I hope you can't hear too much. Anyway. So autoimmune disease, it's important to think about what the immune system does, and the immune system is, or the main role of it is to fight foreign invaders like bacteria, molds, and viruses. But in an autoimmune disease, the immune system produces antibodies that attack the body's own cells, tissues, and organs, and results in this overwhelming inflammatory response. Which eventually causes a damage and dysfunction to a number of different organs in the body. There are more than 80 different types of disorders. Some common ones that you've probably heard of before include rheumatoid arthritis, like you can see here, celiac disease, systemic lupus erythematosus, multiple sclerosis, Hashimoto's, hypothyroidism. Guillain-Barré is quite common. I'm not sure if you would have heard of that before. You might have. And sarcoidosis is also quite common as well. Type 1 diabetes is another one that you've definitely heard of before. Some others you won't necessarily know about them until you come across them obscurely. It's like there's one that I came across called Chagas disease, which only came across as a result of a job that I had, where so it was an RFDS transfer, picked up a patient off the tarmac, and the nurse casually sort of mentioned, "Oh, he's got this thing called Chagas disease. Don't really know what it is, but A, B's, and C's have been fine, OBS within normal limits, but he's just been having a couple of couplets as we started to land." Nothing to be worried about. She was very nonchalant about the whole thing. Anyway, he's coming down for cardiac investigation, is what he said. He's had some episodes of dizziness and chest pain that needs investigation. So I was back then when I actually had a diploma student, so that's how long ago it was. And my diploma student was patient care at that point in time. So I jumped in the front and I said, we popped an ECG on and saw that he'd had a couple of PVCs. And then he also had a few couplets. I said, all right, keep a close eye on that. Let me know if anything gets any worse. So we take off. And we're literally maybe 100 metres away from the tarmac. And she said, so how do you define a run of VT? I said, well, anything more than 2 PVCs is technically a run of VT. And she said, oh, okay. So he's been going since we left the tarmac and he still hasn't stopped. I said, well, that's definitely a run of VT. Anyway, long story short, he ended up having chest pain. Actually, funny, he ended up having chest pain. And she said, so should I give him some GTN? I just remember screaming, no, step away from the GTN, through the cabin of the ambulance. Anyway, pads on, code 1 transport to Prince Charles Hospital. We in conscious VT, and found out later that Chagas disease is this as a result of this parasite that that's from South America, and initially shows these like cold and flu-like symptoms. But if the infection is left untreated, it starts an autoimmune process, and you actually end up with what do they call, Chagas cardiomyopathy or something like that. Anyway, you end up with deadly arrhythmias like VT, and yeah, and then you ended up migrating to Australia and scaring paramedic half to death. Anyway, interesting story. All right, so anyway, let's back to autoimmune diseases. And they're actually reasonably popular, and they affect 5% of the population. But the reason for autoimmune diseases is largely unknown. So let's have a little bit look at the history. I like this stuff. So only as recently as mid-20th century is a time when scientific and medical communities acknowledged the existence of autoimmune disease. Prior to that, and in the first half of the 19th century, people thought that autoimmune disease was biologically implausible. They just thought Peter Ehrlich was a scientist, a biologist, who coined the term horror autotoxicus to emphasize that autoimmunity is just this massive contradictory consideration, and it would totally contradict nature's aversion to self-injury. So everybody's body is trying to protect and self-repair. But when they sort of discovered that allergy and anaphylaxis, and they sort of identified those reasons, those massive systemic responses, they started to believe that autoimmune disease was a thing and that the immune system was actually capable of self-harm. And only as late as the 1960s did ideas about autoimmunity begin to weaken and become more of an acceptable concern. And the first research findings in autoimmune disease were published in 1965. So in saying that, they're still extremely new concepts comparatively to what we know about the body. All right, so fun facts. You can see here this woman's got systemic lupus. She's got that butterfly-shaped lesion on her face. And the word lupus is Latin for wolf, and it's attributed to the 13th century physician Rogerius, who used to describe these erosive facial lesions, and they looked like a wolf's bite, hence the reason lupus. And you can see here that this woman has rheumatoid arthritis, and interestingly enough, in history, the first evidence of rheumatoid arthritis was found in skeletons that were 4,500 BC. Yeah, interesting.
Let's take a walk through autoimmunity. The human body is a haven for life, and much like a prosperous country, is prone to attack. Throughout your entire life, every minute of every day, your body is under invasion from the outside world. Bacteria, microbes, toxins, and parasites have their own specialized methods of attack. Thankfully, your body can defend itself with its own highly sophisticated army, the immune system. Like an army, the immune system is highly diversified, full of specialized warriors capable of countering an attack, however and wherever invasion occurs. On the front lines of the battle, your skin provides a stalwart barrier between outside invasion and the fragile, life-sustaining organs within. To fight off attackers, also known as antigens, that do enter the body, the immune system wields an immense arsenal of cells which work together to prevent disease. Dendritic cells capture antigens and present them to T cells. T cells are the most important immune cells. They can recognize disease-causing microorganisms and rally other immune cells to attack the invaders or kill the invaders themselves. B cells produce antibodies, substances that are designed to attack specific antigens. Phagocytes, like ravenous monsters working for the immune system, are large cells that eat antigens, capturing and destroying microbes and other foreign particles. A healthy immune system will keep the body free of sickness most of the time, recognizing harmful foreign invasion and using its legions of cells to attack sickness-causing antigens. But sometimes, the immune system stops working properly, and instead of attacking harmful intruding antigens, it mistakenly attacks the body's own cells. This friendly fire is called autoimmunity. In an autoimmune disorder, the immune system begins to manufacture T cells and antibodies directed against its own cells and tissues. As a result, healthy cells and tissues are destroyed, which leaves the person's body unable to perform important functions. Nobody is certain exactly why or how autoimmune disorders occur, but contributing factors include genetics and environmental conditions that can trigger the disorder. Some of the known environmental triggers include drugs, viruses, bacteria, foods, pollutants, hormones, and stress. There are hundreds of known autoimmune disorders that affect nearly every part of the body, but some of the most common are rheumatoid arthritis, lupus, Crohn's disease, psoriasis, multiple sclerosis, and vasculitis. Treatments for autoimmune disease include hormone replacement. In some autoimmune diseases, hormone-producing glands are destroyed, leaving the body without key parts of its messaging system. When this occurs, a doctor can prescribe replacement hormones. A common example of this is in the use of insulin in patients with type 1 diabetes or thyroid hormone replacement in Hashimoto's disease. Corticosteroids are used to control inflammation by suppressing the overactive immune system. The disadvantage of this treatment is that it can leave the body susceptible to outside harm because they suppress the whole immune system. NSAIDs, non-steroidal anti-inflammatory drugs, are used to ease pain and swelling. DMARDs, disease-modifying anti-rheumatic drugs, are used to suppress an overactive immune system and can reduce pain and swelling and prevent long-term damage to joints and organs. Biologics, often called immune response modifiers, are a class of drug which interpret the events that drive inflammation by targeting a specific attack rather than a whole-body attack. Currently, scientists are experimenting with stem cell therapy treatments for autoimmune diseases. Such treatments involve reprogramming cells to replace damaged tissue, or replace a patient's immune system altogether by replacing bone marrow, where immune cells are generated. Though millions suffer from autoimmune disorders, more new treatments and research are available to keep the body's defenses aimed towards its enemies rather than towards itself. Brought to you by the American Autoimmune Related Diseases Association.
Okay, all right. So these are some more different types of autoimmune disease. We've covered quite a few of these. We've covered autoimmune hepatitis. Celiac disease and Crohn's disease is something that's quite common. Diabetes mellitus, Graves' disease, Guillain-Barré syndrome, Hashimoto's, MS, myasthenia gravis, which I will cover. Pernicious anemia, that's something we've covered before. It can be an autoimmune disease. It doesn't have to be an autoimmune disease. Primary biliary cholangitis, or otherwise known as biliary cirrhosis, sclerosing cholangitis, and ulcerative colitis. Okay. So, like we said, autoimmune diseases are disorders where the body's tissues are attacked by its own immune system, essentially. And like the video said, like most research into autoimmune disease has not revealed the exact mechanisms that cause this response. We do know that there are various microorganisms and drugs that are triggers of the immune response, particularly in those with genetic predisposition to an autoimmune disease. Another thing that we do know is that it's common for people who have who have autoimmune disorders or an autoimmune condition will often suffer from more than one during their lifetime. All right. So myasthenia gravis. So myasthenia gravis is the cell-mediated destruction of acetylcholine. So you might recall that acetylcholine is a neurotransmitter, that the neuromuscular junction, and that's responsible for carrying messages from nerves to muscles and causing them to contract. The condition results from an autoimmune attack on these on the acetylcholine receptors, and they're postsynaptic, and it means that the neuromuscular transmission doesn't occur. The exact cause is unknown, but they do know that it's often associated with SLE and pernicious anemia, and that there's commonly thymus involvement. So the thymus involvement, more than 65% have thymus hyperplasia, and 10% of people with myasthenia gravis have a thymoma, and of which about half are actually cancerous or malignant. Myasthenia gravis develops most commonly in women from 20 to 40 years old, and men aged 50 to 80, but it really can occur at any age, and including childhood. So the most common symptoms that you'll see is muscle weakness, easily fatigued, ptosis, which is that drooping of the eyelid, and diplopia, so double vision, essentially. An acute presentation or an emergent presentation is the myasthenic crisis, which is this severe generalized quadriparesis, and it can result in life-threatening respiratory muscle weakness, and occurs in about 15 to 20% of myasthenia gravis patients at some point in their lifetime. And it's often preceded by some sort of infection that reactivates the immune system. It is good to note that once respiratory insufficiency begins, that respiratory failure can occur rapidly. So priority treatment for these patients is good quality ventilations and transport to a hospital where they can be intubated, and they will stay on a ventilator, and these symptoms are commonly self-limiting. Okay. All right, Guillain-Barré syndrome. Another reasonably common syndrome. It's usually really quickly progressive in inflammatory polyneuropathy, but it is self-limiting. Okay, so it will stop by itself. It is the most commonly acquired inflammatory neuropathy, and often as a result of some really banal infection, which means super minor, not even considered infection, minor surgery, or even a recent vaccination. And the symptoms can occur between 5 days and 3 weeks after these events happen, these initial insults happen. So symptoms are this flaccid paralysis, this significant muscle weakness, and people who've had Guillain-Barré syndrome will tell you it happens. They'll notice it in their feet, and it just starts to ascend in both feet all the way up their body, and they all of a sudden just feel weak and like they can't use their legs, and it's this paralysis. Some have even described it as a heaviness that occurs from their feet all the way up. They get this loss of sensation, and eventually it gets as far up that they end up with respiratory paralysis. It is also noted that patients get an autonomic dysfunction and often have cardiac arrhythmias. And in some severe cases, they can end up with GI stasis and urinary retention as a result of muscle paralysis. But like they said, like you can see here, it often is that the sphincters are spared. So the sphincter's still retaining the urine, so it won't necessarily come out. So this condition is self-limiting, like I said before, and it will typically resolve after a few weeks. Treatment is commonly managing symptoms, so managing ventilation, so airway and ventilation, and treating the patient with fluids and nutrition and just managing the symptoms. All right, ulcerative colitis is something that I have seen quite a bit in the emergency setting. And you see the initial onset, which is that that watery or mucousy blood and pus in diarrhea. And that's as soon as somebody sees blood in their diarrhea, they will commonly call the ambulance because they're concerned about uncontrolled blood loss, which is fair. So ulcerative colitis is this chronic inflammatory and ulcerative disease of the large intestine, only the large intestine. It commonly starts in the rectum, and it sometimes will just stay in the rectum. And that has a different name. It might be, I have to look it up, but it's ulcerative rectina. I can't remember. It does have a different name, the one that just stays in the rectum, but it is essentially the same disease. So common symptoms for ulcerative colitis: you get this bloody diarrhea, and you can go to the toilet 10 or more times a day, and it's just super watery. Get quite severe lower abdo pain, and they will commonly have other autoimmune disorders as well, like arthritis. Ulcerative colitis can predispose its sufferers to colon cancer as well. Toxic colitis is a medical emergency, an extension of ulceration results in localized ileus and peritonitis. So ileus is where the bowel just stops moving. The colon loses muscle tone, and it can be just this spontaneous onset with severe colitis, or as a result of taking medications that the patient's not used to. The inflammation affects the mucosa and the submucosa, and in severe situations it will affect the muscularis, which is this thin layer of muscle that just sits underneath the submucosa. In toxic colitis, colonic perforation can occur, and if that occurs, there's a significant mortality rate. So symptoms of toxic colitis is this sudden violent diarrhea, super high fevers, significant abdo pain, and symptom of peritonitis. So it's basically an acute surgical abdomen in toxic colitis. And there is a video. Is that going to work? Yeah, it works. A little bit more about toxic colitis. Or not toxic colitis, ulcerative colitis.
Inflammatory bowel disease can cause inflammation in the small and large intestine. In other words, inflammation of the bowel. Colitis refers specifically to inflammation in the colon, or the large intestine. Ulcerative colitis is a type of inflammatory bowel disease that tends to form ulcers along the inner surface or lumen of the large intestine, including both the colon and the rectum. These ulcers are spots in the mucosa where the tissue has eroded away and left behind open sores or breaks in the membrane. Sometimes there's a flare, which means that new damage has occurred, and then there are periods of remission when the tissue starts to heal up. Ulcerative colitis is actually the most common type of inflammatory bowel disease. Not that there are that many, but this one causes inflammation and ulcers in the mucosa and submucosa of the large intestine only, which is an important point that sets it apart from Crohn's disease, another inflammatory bowel disease. Now, although certain environmental factors like diet and stress were once thought to be the culprit behind these ulcers forming in the gut, now it's thought that these are more secondary, meaning they seem to make the symptoms worse, but ulcerative colitis is now ultimately thought to be autoimmune in origin. In fact, cytotoxic T cells from the immune system are often found in the epithelium lining the colon. So the thought is that inflammation and ulceration in the large intestine is caused by T cells destroying the cells lining the walls of the large intestine, leaving behind these eroded areas or ulcers. It's unclear what exactly these T cells are meant to be targeting though. Some patients have p-ANCAs in their blood, or paranuclear anti-neutrophilic cytoplasmic antibodies, which are kind of antibodies that target antigens in the body's own neutrophils. Although not completely understood, some theories suggest this might be partly due to an immune reaction to gut bacteria that have some structural similarity to our own cells. allowing antibodies to those gut bacteria, or P. ANCAs, to cross-react with neutrophils. Patients also seem to have a higher proportion of gut bacteria that produce sulfides, and often high sulfide production is correlated with periods of active inflammation as opposed to remission. Ultimately, though, these are mostly correlations and theories, right? And we've yet to nail down the precise mechanism behind mucosal destruction. The cause is ultimately some combination of environmental stimuli, perhaps the sulfide-producing bacteria, mixed with a genetic predisposition, because patients with a family history of ulcerative colitis are more likely to develop the disease themselves. It also seems to be more common in young women from the teens to their 30s, with more prevalence among Caucasians and Eastern European Jews. With ulcerative colitis, the pattern for ulceration seems to be circumferential and continuous, meaning that the inflammation goes around the whole lumen and starts in the rectum and continues along the large intestine without any apparent breaks of normal or unaffected tissue, like it's working its way from one end to the other. As more damage is done to the tissue, patients experience pain in the left lower quadrant, which corresponds to the rectum, and more severe and frequent bouts of diarrhea, sometimes with blood in the stool as well. As the mucosa and epithelium are destroyed, blood and serum may be released into the lumen, which contributes to the blood seen in the stools. But also, what's one of the main jobs of the large intestine? It's absorbing water, right? As these cells are destroyed, the large intestine can't perform this function as efficiently and ends up letting too much water through, contributing to diarrhea. Treatment for ulcerative colitis depends on the severity of symptoms. Often anti-inflammatory medications are given, like sulfasalazine or mesalamine. In more severe cases, though, drugs that suppress the immune system, like corticosteroids, azathioprine, or cyclosporine, might be prescribed. Finally, if these treatment options fail, sometimes a patient will have a colectomy, which is a surgical removal of the colon. Since the disease only affects the large intestine, removal of the colon generally cures the disease. But you have to weigh the benefits of curing the disease against the total loss of the large intestine.
Okay, so that's it about ulcerative colitis. Okay. All right. So now on to rheumatology. Oh, actually, and I found out what back to ulcerative colitis. Ulcerative colitis, this is just in the bowel, is called ulcerative proctitis. So it is, yeah, that's what it's called, ulcerative proctitis. Not that it makes much of a difference, but it was going to kill me. Anyway, rheumatology. So rheumatology is the study of rheumatism, arthritis, and other disorders of the joints, bones, muscles, and ligaments. Rheumatism is basically any disease marked by inflammation and pain in those areas. So the joints, muscles, fibrous tissue, and ligaments. Okay. So, common conditions are associated with inflammatory and connective tissue diseases, mechanical musculoskeletal conditions, and commonly managed by immunosuppressants, antibiotics, and steroids. So, rheumatoid arthritis is probably one of the most common presentations of rheumatology that you'll ever see. It's an autoimmune disease that causes this chronic inflammation of the joints. And it can also cause inflammation to the tissue around the joints, as well as other organs in the body. The inflammation of rheumatoid disease can be such as tendons and ligaments and muscles. In some patients with rheumatoid arthritis, chronic inflammations can lead to destruction of the cartilage, the bone, and the ligaments, and cause significant deformity, like you see in this X-ray here. Damage to the joints can occur quite early in the disease process, and it can progress as the individual ages. So you will notice that it happens quite a lot in the older populations. Because RA, or rheumatoid arthritis, or RA, can affect multiple organs in the body, it's referred to as a systemic illness, and sometimes called rheumatoid disease. The primary factor is this joint inflammation, and it causes swelling and pain and stiffness and redness in the joints. and it can be a chronic illness, which can last for years. Even though patients can experience long periods without symptoms, however, typically rheumatoid arthritis is progressive, and it has this potential to cause joint destruction and functional disability. It's a common rheumatic disease, and it affects about 2% of the population in Australia. It's 3 times more common in women as it is men, and it doesn't specifically affect any particular race. It affects people of all races equally. It can begin at any age, but most often starts after 40 and before 60. The fact that lots of people in the one family can be affected by RA suggests that there is maybe a genetic basis for the disorder. So juvenile rheumatoid arthritis is an arthritis that causes joint inflammation and stiffness for more than 6 weeks in a child that is 16 or younger. It occurs approximately 1 in every 1,000 children in Australia, and it has very similar symptoms as rheumatoid arthritis in adults, causing redness, swelling, warmth, and soreness to the joints. Even though so many children with juvenile rheumatoid arthritis don't complain of pain, but they will complain of lack of mobility, and that's as a result of the inflammation. It's expected that the cause of juvenile rheumatoid arthritis is due to certain infections or potential factors in the environment that trigger that immune system response. For rheumatoid arthritis, not specifically juvenile rheumatoid arthritis, scientists have reported that smoking tobacco increases the risk of developing rheumatoid arthritis. And lucky for me, there's no real research into alcohol that I've found, so I'm good so far. May have liver failure, but might not get rheumatoid arthritis. So the symptoms of rheumatoid arthritis can commonly come and go, but when the tissues are inflamed, it's considered active. And when the inflammation subsides, the disease is in remission. And remission can occur as a result of treatment, or it can be spontaneous, and it can last weeks or months or years. And patients will generally be asymptomatic and feel well, but when the disease becomes active again, this is called a flare. So that's when the patient is experiencing those rheumatoid arthritis symptoms of pain and swelling. So because we said that it is a inflammatory disease, inflammation can affect other organs of the bodies other than joints. So other examples may be Sjogren's syndrome, which is a associated disease with rheumatoid arthritis, and it affects the eyes and causes inflammation of the glands of the eyes and mouth, and causes dryness in these areas. You can actually get rheumatoid inflammation of the pleural lining, and causing pleuritis, and this causes like a deep chest pain with breathing and difficulties and coughing. Tissue inflammation surrounding the heart can be caused by rheumatoid inflammation, and that can be pericarditis. And it's that type of chest pain that typically changes when the patient is sitting up or leaning forward or lying down. Rheumatoid arthritis can reduce the number of red blood cells, causing anemia, and white blood cells, causing neutropenia. You can also get these firm lumps under the skin called rheumatoid nodules, and these often occur around the elbows and fingers where there is frequent pressure, but they can also occur in the airway, causing airway obstructions. There is a rare and pretty severe presentation of rheumatoid inflammation that happens in the blood vessels called vasculitis. And it can impair blood supply to tissues and organs and can cause tissue death, which is obviously not ideal. First signs of it is commonly noticed in tiny black flecks around the nail beds or on the legs as skin ulcers. We know that there's no real cure for rheumatoid arthritis, and to date, the goal of treatment is to reduce the inflammation and maximize joint function and prevent joint destruction. Okay, sorry about that. Back to rheumatoid arthritis. So here we've got just a little bit of a summary, essentially. So we talk about 2% of the population having it, more common in women. Commonly, the pain is worse in the morning, and you can get more than one joint affected. And you'll commonly get symmetrical involvement. Osteoporosis is a common finding, so you'll get rheumatoid and osteoarthritis at the same time. Commonly, the hand and the wrist are those mainly affected joints, and you'll see this type of, like we did in that x-ray, that type of classical deformity in the hands. But you can get rheumatoid arthritis in the hip and the knee joints and even in the cervical spine. It's not uncommon to get sepsis as a side effect of the immunosuppressive drugs because they're more prone to infection as their immune system is being suppressed. And can cause systemic effects due to local inflammation around the organ sites and can result in neutropenia and splenomegaly, which is a specific type of condition called Felty's syndrome. And so the neutropenia is due to this chronic inflammation, and then there's this chronic activation of neutrophils, which eventually becomes exhausted and progresses to neutropenia. And splenomegaly in this instance is an inflammatory response. And rheumatoid arthritis, neutropenia, and splenomegaly together is known as Felty's syndrome. So, medications or treatment of rheumatoid arthritis. So we know that there's no known cure for rheumatoid arthritis, and to date, the goal of treatment is to reduce inflammation and pain, maximize function, and prevent joint destruction and deformity, as we said before. So there are two classes of medications used in treating rheumatoid arthritis. So we've got the fast-acting first-line drugs and slow-acting second-line drugs. And these ones are also referred to as the disease-modifying anti-rheumatic drugs, or DMARDs. The first-line drugs are commonly drugs such as aspirin and corticosteroids, and these are used to treat pain and inflammation. And the slow-acting second-line drugs, such as gold or methotrexate, hydroxychloroquine, or Plaquenil, promote disease remission and prevent progressive joint destruction, but they aren't analgesics or anti-inflammatory agents. There's some other treatments that people try for rheumatoid arthritis. So fish oil is thought to have anti-inflammatory benefits. There's no particular diet that you need to eat. And cartilage preparations like glucosamine largely remain unproven, but people still take them. And pain relief, people will take paracetamol quite regularly for for pain relief, and they'll even go as far as having topical preparations which are rubbed into the skin, like Voltaren or something like that. Okay, and these are the common names of the drugs that are used to treat arthritis. Methotrexate is probably one of the most common. It's an immunosuppressive medicine, which means that it works by reducing the activity of the immune system and essentially the immune response and or the inflammatory response. So in rheumatoid arthritis, it helps to reduce the inflammation in the joints and helps to reduce pain and swelling. And it also potentially limits damage to the joints and helps prevent disability in the long term. And because it reduces the damage to the joints rather than just relieving pain, it belongs to the group of medicine called the disease-modifying anti-rheumatic drugs, or DMARDs. And gold, even though it seems quite obscure, but it is used. It was discovered accidentally by a French physician who was using gold salts to treat tuberculosis, and noticed that if he injected gold salts into a tuberculosis patient, their arthritis was also cured. So it's been used to treat arthritis ever since. It's not well known how the mechanism works, but apparently it interferes with the function of the white blood cells responsible for joint damage and the inflammation. Yeah. I mean, it is thought that it slows destruction of the joints, but it can't correct existing joint deformities. So yeah, it just sort of helps to slow everything down, I guess. It's a stopper. All right. So arthritis, acute monoarthritis, can actually lead to a really serious presentation that, if left unchecked, can lead to rapid joint destruction and even death of the patient altogether. And that serious presentation is septic arthritis. It's commonly caused by a staphylococci or a streptococci when the bacteria enters the synovial lining of the joint. So, in around here. So the synovial membrane, and that's where the bacteria gets in. And it's caused by soft tissue infections or penetrating trauma close to the joint. This is not an uncommon presentation in children, as because they tend to fall and scrape their knees all the time. And so, yeah, it's not an uncommon presentation in the pediatric population. And it presents with joint pain, really limited movement in that particular joint that's affected, and you'll get this quite pronounced joint swelling in most cases. It's harder to tell if they've got septic arthritis with the hip, but it's quite easy to tell if they've got in their knees, and that's often where kids will get it. These joints will be warm, reddened, and really sore to touch, and they'll get all the same sort of symptoms of infection, like sweats and rigors, and they'll be quite febrile. Our management of this is to treat the sepsis, treat with analgesia, and take to hospital. And patients can be quite unwell with these, and the symptoms can progress quite rapidly, especially if they're taking any immunosuppressant medications. So just be aware of the patient with rheumatoid arthritis, with septic arthritis, or patient with arthritis with fever. Okay, rheumatology, some more rheumatology. So let's look at psoriasis. It's a common skin complaint, and it commonly affects 1 to 2% of the population. Main features is this red or scaly, silvery, scaly area or patch, and they commonly appear on knees or elbows. They can sometimes appear on the scalp and other parts of the trunk and legs. It is not a discriminating rheumatism, as it affects both sexes and all races and can occur at any stage in life, but it starts most frequently in young adults. Excuse me. It's currently thought that the main problem in psoriasis is an increased activity of the immune system in the skin, causing these lymphocytes or white immune cells to accumulate in the skin, and they produce these range of chemicals, and these chemicals trigger changes in the skin which lead to an abnormal rate of skin multiplication, which in turn causes these thickened, reddened, silvery type of keratoderma, or the thickened skin. Yeah, and it can contribute to sensations of skin irritation and be itchy. It's one of those, because it's rheumatic, it can be managed with topical treatments, medication, and oral steroids. And then patients can be prone to flare-ups as well. I can never say this word. Psoriatic arthropathy, basically meaning psoriasis and arthritis associated together. So this affects 10 to 40% of patients who already get psoriasis, and they get this arthritic joint disease associated with skin inflammation and scaling. Nail changes are interestingly a characteristic feature, and 90% of the sufferers have nail changes. In some patients, the arthritic symptoms will affect small joints at the end of their fingers and toes. In others, it will be joints on one side of the body, but not in others. You can see here some other symptoms that you might see. Oh, wait. What am I up to? Most people develop psoriatic arthritis at between the age of 35 and 45, but it has been observed in adults a little bit earlier and even in children. Both the skin and joint symptoms will come and go, and there's no clear relationship between the severity of psoriasis and arthritis pain, or the severity of arthritis pain and the psoriasis. And it's unclear how common psoriatic arthritis is. Some surveys suggest, some more recent surveys in 2014 suggest that between 1 in 5 people and 1 in 2 people with psoriasis may also have arthritis symptoms but are currently undiagnosed. So reactive arthritis. So let's have a look. So in order to diagnose psoriatic arthropathy, the rash usually precedes the arthritis by a few years, but the opposite is occasionally true. Sometimes they will get the arthritis and then develop psoriasis. Family history may be a clue to the etiology of arthritis in some cases. And some patients will only have those nail changes that we see here other than a rash. Nails might show this pitting, yellowing, which you can't really see here. That almost looks like a fungal infection in that one. You get transverse ridges. So these are ridges that you see here, and just complete destruction, or onculitis, it's called, onycholysis. Destruction is much easier to say. Okay. Reactive arthritis is an type of arthritis that's usually caused following certain infections. Commonly STIs like chlamydia. And you can also, as a result of gastrointestinal disorders like Shigella and Salmonella and Campylobacter, or even longer term HIV and co-infections of STIs. It develops a few weeks after the infection, usually, with symptoms including pain, swelling, and stiffness in a joint, usually on one side. You get this lower back and buttocks pain and inflammation of the tendons. And you can often get psoriasis as a result, and sometimes these sausage toes as a result as well. And the pain commonly comes from pain and inflammation of the tendons. You can get pain and redness in the eyes and sometimes conjunctivitis. And you'll see this keratoderma, or this thickening of the skin on the palmar and the plantar surfaces. It's simply managed with analgesia and antibiotics or antivirals to fight the initial infection, non-steroidals for joint inflammation, steroids for severe pain, and DMARDs as well. It's usually self-limiting, and the symptoms will resolve between 6 and 12 months. So rheumatic fever is one that you probably have heard of before, even though it's not particularly common anymore. It is an inflammatory disease and commonly develops after an infection with streptococcus or group A strep. Mainly affects young children and occurs around 20 days after strep throat or scarlet fever, and is the most common cause of chronic structural heart disease in developed countries. So let's talk about group A strep. So group A strep is a bacterium often found on the throat and on the skin. And people carry group A strep in the throat and on the skin and have no symptoms. Most group A strep infections are relatively mild, such as strep throat or impetigo, and occasionally they can cause severe life-threatening diseases. So the features of rheumatic fever is that it's thought to be the result of a hypersensitivity reaction caused by the cross-reacting antibodies. And it's thought that there's this combined humoral and cell-mediated immune response to the bacterium, so to the group A strep. Like we said, it's the most common cause of chronic structural heart disease in developed countries. And the disease can affect joints, skin, heart, and nervous system. Causes 90,000 deaths per year and chronic rheumatic heart disease in an estimated 30 billion children and adults. The incidence is highest in school-aged children between ages of 5 and 15 years, and the median age is about 10 years. 20% of cases occur in adults. The incidence is particularly high where there is overcrowding, so when people are living in close proximity to each other. Interesting to note that the Indigenous populations of Australia and New Zealand have some of the highest incidence recorded in recent years, with 374 per 1,000 per year in the 5 to 14-year-olds getting rheumatic fever. Sub-Saharan Africa has the highest estimated regional prevalence of rheumatic heart disease. And these symptoms appear about between 1 and 5 weeks after a sore throat, with an average of 3 weeks in occurrence. And recurrent cases in this incubation, recurrent cases actually increase the patient's risk of developing that rheumatic heart disease. And so you will be diagnosed with rheumatic fever, and it's based on the Jones criteria. These were devised in 1944 but were revised in 1992, and they're used to identify patients with a high likelihood of having rheumatic fever. So the major criteria for diagnosis that you can see here in the Jones is polyarthritis or painful joints, carditis, pancarditis, nodules, erythema marginatum, and Sydenham's chorea. Minor criteria. Let's go. So arthritis is polyarthritis. Heart inflammation is carditis. Nodules under the skin, so subcutaneous skin nodules. Sydenham chorea are these rapid, jerky movements, and erythema marginatum is a reddened skin rash. The minor criteria include fever, erythrocyte sedimentation rate, which is something that you need to take by bloods, or arthralgia, and a long PR interval. So you're commonly diagnosed with Jones criteria if you've got two of the major, or one of the major and one of the minor, or two of the minor, is that right? Oh, sorry, you're likely diagnosed with rheumatic fever if you meet two major criteria or one major and two minor, and have signs that you've had a previous strep throat. So that's a streptococcal infection of the tonsils or the pharynx. Okay, so rheumatic heart disease is what is a common presentation as a result of rheumatic fever, and it's the damage to one or more heart valves after acute rheumatic fever is resolved. It's more likely to occur in acute or when you've got recurrent episodes of rheumatic fever. And so what occurs are the heart valves actually become stretched and scarred, and it interrupts cardiac blood flow through the heart. And as a result, patients can end up with endocarditis, arrhythmias, stroke due to the stasis inside the heart, and endocarditis. Patients may actually, so patients often symptomatic or have no symptoms or very mild symptoms for years. So mild symptoms might include shortness of breath with exercise and palpitations. However, complications can develop and often do, and can occur during pregnancy because of the extra strain placed on the heart. All right. Lupus. There's two main types of lupus. The systemic lupus erythematosus, or SLE. Lupus is an autoimmune disease. With lupus, the immune system produces an excess of proteins called antibodies, and they attach themselves to various things in the body. Accumulation of these antibodies in the tissues can cause inflammation, damage, and pain. The cause of lupus is still not known, even though it's probably one of the first autoimmune diseases recognized. Scientists believe that there's several things that may trigger the formation of antibodies, including genetics and hormone and environmental factors. Some triggers are thought to possibly be hormones, especially in females, because females between the age of 15 and 45 are commonly affected. So that's during childbearing period, essentially. Certain medications, dietary factors, microorganisms, genetics, pregnancy, and exposure to UV light. Although it can affect anyone, it's 90% of lupus patients are actually women. And like we said, 90% develop the condition during their reproductive years. Systemic lupus erythematosus affects almost any body system or any system of the body. In most patients, only the skin and joints are affected, and this is called minor threatening. This is called minor threatening lupus. In others, systemic lupus can affect kidneys, heart, lungs, blood vessels, and brain even. And that's a really major type of lupus. Raynaud's phenomenon can occur in fingertips and in toes and also in the nipples as well. And it is an acute vasospasm and can actually end up causing necrosis to the fingertips, the toes, and the areola. The Raynaud's phenomenon will commonly occur whilst a woman, if she manages to get pregnant while she's got lupus, but will commonly occur while she's breastfeeding. Okay, so discoid lupus, also known as chronic cutaneous lupus, erythematosus, usually appears as a red scaly rash on sun-exposed areas such as the face, scalp, arms, legs, or trunk. It's generally a milder disease than SLE, and it's diagnosed by its appearance or by a biopsy on the skin. A small number of people with discoid lupus will develop SLE. However, most patients with discoid lupus have their condition confined to the skin only. So lupus can affect lots of parts of the body, but the most common symptoms are that skin rash, and although most skin rashes can occur, you commonly get this butterfly type skin rash on the face, and it affects about 2/3 of the patients. Joint pains, also known as arthralgia and inflammation, arthritis, are common features. 9 out of 10 patients experience some form of joint pain. Most commonly hands, wrists, and feet. How, during active disease, patients with lupus can experience significant hair loss, and even alopecia can occur as a result. Patients can experience tendinitis, and when they are inflamed, they can tighten, causing patients' fingers to sort of pull into abnormal positions, such as trigger fingers. And that's when this is unusual, but is a possibility. Muscle aches, and technically known as myalgia, occur in 2/3 of patients. And the muscles between the elbow, the neck, and the knee are most frequently involved. Again, because like in other forms of rheumatology, you can end up with inflammation of the pleura, called pleuritis. A kidney condition called lupus nephritis can sometimes develop, which is an inflammation of the nephrons and can affect the delicate filtering mechanisms of the kidney. Lupus can affect the cells of the blood system and the components of the system that are involved in blood clotting particularly. The most common complaint in hematology with lupus is anemia, or too few red blood cells in the bloodstream. Patients can end up with lymphadenopathy or swollen lymph nodes. Severe circumstances, brain and nervous system. The brain and nervous system can be involved, especially with inflammation of the blood vessels, causing a variety of symptoms from depression to seizures to visual disturbances. Lupus is not easy to diagnose, and symptoms are often similar to other diseases and tend to come and go, and diagnosis is usually clinical. Yeah, so not the most fun disease to have in the world. So like we said, excuse me, a little bit of a summary about lupus or systemic lupus. 20 to 40-year-old females, so in that childbearing age. I think I said 15 to 40, so obviously two different references here. Also can occur in children and older adults, but 90% of the patients are female and 90% of those situations onset whilst during reproductive years. The underlying mechanism is obviously an autoimmune response with that production of antibodies, and the body just doesn't suppress them. Yeah, and they bind to various different tissues around the body. And the mortality after diagnosis averages about 5% per year. And so here's a picture, another picture of that butterfly type rash. And here's some of the most common type of systemic lupus erythematosus symptoms. Right, oh, I've got it here again. So, significant conditions, we talked about renal injury failure, can lead to hematuria due to the nephrons becoming leaky, or actually the inflammation causing blood loss as well. The central nervous system becomes excitable, can cause seizures, can cause stroke, and as well as psychosis and migraines. More prone to hemolytic anemia, thrombocytopenia, and leukopenia. And we talked about peripheral vasculitis as a result of Raynaud's syndrome, and that vascular spasm. And so the management of systemic lupus for us is symptomatic. So treat pain, treat fluid loss, manage ABCs, and transport to hospital. Long-term management of lupus includes anti-inflammatory drugs, so those first-line drugs, and taking care of yourself and trying to avoid emotional stress, fatigue, and excessive sun exposure. Okay, so rheumatic disease is an emergency care, what we might actually see in an acute setting, because a lot of that is chronic, and sort of wondering how this applies to pre-hospital environment. All right, so there's a few things that might be important for us to remember, or consider when we're taking history of these patients who are presenting with these rheumatic conditions or these autoimmune conditions. So SLE, so patients might appear with serositis and effusion, especially in the pleura and in the lungs, and can cause shortness of breath, chest pain. Yeah. So yeah, the serous tissue lines the lungs, and so and the heart and the pericardium, and the inner lining of the abdomen, the peritoneum, and the organs within. Rheumatoid arthritis. We talked about the rheumatoid nodules, and how they might actually create an airway obstruction, and that's difficult to manage if you've got another obstruction as well as the nodules, confounding everything. Spondyloarthropathies is any joint disease of the vertebral column, and it's this diverse group of inflammatory arthritis, and they show genetic predisposition and clinical features, and the most characteristic feature is inflammatory back pain. So ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease, and undifferentiated spondyloarthropathy can all cause acute respiratory distress syndromes and breathing problems. Polychondritis. So polychondritis is specifically refers to the ribs, or the cartilage in the rib cage, and inflammation of this can actually cause breathing problems. Polymyositis is characterized by inflammation and degeneration of the muscles. Dermatomyositis is polymyositis accompanied by skin inflammation, and these can both cause inflammation of the pleura and breathing problems. Scleroderma is this widespread connective tissue disease that involves changes in the skin and the blood vessels and the muscles. And the patients are at greater risk of developing interstitial lung disease. Wagner's granulomatosis. This is a rare form of vasculitis. And it's actually a multi-system disease and affects many parts of the body. And it is most characterized by the ELK classification. It's commonly presents with lesions in the upper respiratory tract, E, indicating ear, nose, and throat. Almost 100% of the time, patients get these lesions in the ear, nose, and throat. They get lesions in their lungs. Most patients get these. And kidneys, so that's the ELK. Ear, nose, and throat, lungs, and kidneys, lesions in all of these. Many of the other body systems can be presented as well, but they are the most common. Polyarteritis nodosa. It's this disease that really doesn't have any known cause, and it can affect the arteries and the blood vessels that carry oxygenated blood to the organs and tissues. And it occurs when immune cells attack the affected arteries. More adults than children get this disease, and it damages the tissues supplied by the affected arteries because the tissues are not getting blood, therefore they're not getting oxygen, therefore they're not able to function. Okay, right, so let's take a look at some of the musculoskeletal conditions that we're going to look at. All of these are quite common presentations in either chronic or acute settings in the ambulance. And we should know how to recognize and to manage them. These are less sexy than traumatic musculoskeletal issues, but they're just as emotionally traumatic for patients as they cause pain. And, sometimes they're more emotionally traumatic because they're not unconscious like lots of our trauma patients. So, it's something that you need to be mindful of. All right. So, bursitis. So, a bursa is this fluid-filled sac that sort of fits in between the joints and helps to lubricate the joints. Yeah. And when you've got inflammation of these, it can be extremely painful. It can end up and also causes, where are we? What are we doing? So tennis elbow or lateral epicondylitis is, where are we? Here we go, tennis elbow. So that's your lateral epicondylitis there. So this part of your olecranon or your elbow joint essentially, and it's the distal part of the humerus essentially. And that caused by repetitive strain and over that extensor tendon and can cause significant pain in that extensor forearm muscle, causing elbow and forearm pain. The golfer's elbow, which is more on the inside, basically the same bone on the medial aspect of that arm there. So it is on the other lateral epicondyle essentially, and it's as a result of tendon inflammation and sometimes these tiny tears along there as well. Again, caused by repetitive stress at the muscle tendon junction, and this is often a clear history of likely cause of repetitive strain or possibly history of an acute injury to the elbow. Usually unilateral for both of these, sometimes bilateral. And for us to manage is all very symptomatic. Manage pain, airway, breathing, circulation. Okay, so bursitis, like we said, bursitis is that fluid-filled sac that can sit either in between or outside the joint in order for it to be lubricated. So that protects the head of the ulna there, so that when we tip it down on like tables or something, we're less likely to get a painful reaction. Okay. So the olecranon bursitis is an inflammation and swelling behind the elbow, so in that space. And that's what you might end up with. Can be due to trauma, so you can cause significant inflammation as a result of trauma. Can be due to gout or hyperuremic collection there, or infection in your bursa. Bursitis in your prepatellar bursitis, so just at the bottom of your knee here. So you can see prepatellar bursa. So it's that one that sits on top of your knee. Again, it helps to protect your kneecap when you're kneeling down. It's secondary to friction or occasionally infection. Used to actually be referred to as housemaid's knee. Probs can't say that anymore. And it's now more commonly known as carpet layer's knee, but you can probably call it in our situation CPR knees, unfortunately. And that's probably the only thing that you can relate it to in paramedicine. Okay. Again, management for us in the out-of-hospital environment is analgesia and transport to hospital. The patient will need anti-inflammatories, probably steroids. If not, they can drain the excess fluid from the bursa. Okay, let's look at a bit more of the connective tissue damage and inflammation. So tendons themselves, we're looking at tendons, are cords of tough, fibrous connective tissue that attach muscles to bones. Some, but not all, are covered by a sheath called the synovium. And this synovium makes this tiny amount of oily fluid which lies between the tendon and its overlying sheath. And it helps the tendon to move freely and smoothly when it pulls the bone it's attached to. Tendinitis and tendinosynovitis are types of tendon injury, and they can often occur together. Tendinitis means inflammation of the tendon. Tendinosynovitis means inflammation of the sheath that surrounds the tendon. The sheath is called the synovium, which we talked about just before. These injuries typically occur when the tendons are overused. For example, this may be as a result of playing sport or overuse in the course of work. Can commonly occur around the wrist, overuse by lots of typing or assembly line work. And this can trigger a significant inflammation in the area. And it's commonly referred to as RSI, or repetitive strain injury. So in some cases, tendinosynovitis. We'll go back. I missed that. In some cases, there's no history of overuse of the tendon, and it seems to occur for no apparent reason. But there are some other causes that can cause tendinitis and tenosynovitis. So arthritis, especially some types such as rheumatoid arthritis, can cause inflammation in the tendon sheath, as well as infection. This is quite rare. Although infection may occur because of a cut or puncture over the tendon, and it may allow bacteria to get in to infect the tendon or the tendon sheath. However, infection may spread to other parts of the body and the patient may end up as septic. It may be difficult to differentiate between that and septic arthritis, but our out-of-hospital management is quite similar. So tendinopathy is usually referred to as an occult presentation of pain and swelling with a significant history of repetitive strain injury or something that's making it more likely that the inflammation is as a result of tenosynovitis or tendinosis. De Quervain's tenosynovitis occurred to me most recently. I thought it was carpal tunnel. It's actually De Quervain's tenosynovitis, and it's this common condition that affects the tendons that are used to strengthen or used to straighten your thumb. And I've realised that I use it when I'm working as a midwife more often, especially if I'm working on the ward, and it's as a result of using very fine motor skills to dress teeny tiny babies. So there you go. So that's my repetitive strain injury from dressing too many babies. And it's this pain over your wrist at the base of your thumb, and it's made worse by activity. Trigger finger, which is what we talked about before, is where you get the tendinitis usually in the ring finger, and it prevents your finger from straightening fully, so it looks like you're holding a gun essentially, hence the trigger finger. Tennis elbow, lateral epicondylitis. We talked about this. Again, it can be as a result of repetitive strain injury and inflammation to the tendon over that lateral epicondyle in your elbow. Golfer's elbow is similar sort of presentation, but on the medial epicondyle, so the inside of the forearm. And it's as a result of too much golf causing repetitive strain injury and inflammation of the tendon, and sometimes some very minor tearing. You can get tendinitis in anywhere that you have a tendon, essentially. Some of the more common ones that we get in the ambulance service is rotator cuff tendinitis. And that's as a result, well, it used to be as a result of lifting the defibrillators in and out of the back of the truck. Now that they've changed the orientation of the defibs in the truck, it's less of a concern. And I believe OH&S has had a significant drop in workplace health and safety injuries. There's no real proof that you can prevent any tendinitis, especially if you're doing a job where you've got repetitive strain. I mean, ideally you would like to minimize and avoid repetitive movements and overuse of these areas. But this is something that you'd need to look at with your employer if it was an ongoing concern. Osteoarthritis. Osteoarthritis is referred to as the deterioration of the joints, and it becomes more common with age. Knees and hands are most common affected, with pain and stiffness ranging from minor to significant. And osteoarthritis is one of the most common forms of arthritis and commonly develops from the age of 45, although it can occur in younger people. Many of us will probably develop symptoms as we age, especially after menopause for women, because your bones, after you lose estrogen, your bones actually start to become leached and will lose calcium deposits. Fun. So osteoarthritis also occurs and can occur, can cause a breakdown of the cartilage in between the joints. So symptoms of osteoarthritis can vary from one person to the next. Most common symptoms include pain and stiffness and muscle weakness. Yeah, so the risk factors for osteoarthritis is unclear, but you're more likely to get osteoarthritis if you've had a family history, a previous injury in the overuse of the joint, and being overweight makes you more prone to osteoarthritis. No cure for osteoarthritis, but it can be managed. And keeping an osteoarthritic joint exercise is important to maximize the health of the joint and maintain joint movement and muscle strength. So as cartilage doesn't have a blood supply, it doesn't get repaired. So keeping the joint mobile and active is one way to ensure that you have a less of an effect on your body. Osteoporosis is commonly associated, but not exclusively. Oh, so sorry, I confused osteoarthritis to osteoporosis before. So forget what I said about postmenopausal women getting osteoarthritis. They still will get osteoarthritis, but it's not as a result of bone leaching. Well, I guess you can. It probably is combined factor. So yeah, don't discount that. But I'm guessing osteoporotic bone is probably more prone to osteoarthritis, where those joints are going to start to degrade. That's probably, yeah, maybe less so because it's more as a result of cartilage loss and then joint destruction, which I guess will occur as a result of osteoporosis. Now I've just confused myself. Anyway, so osteoporosis is commonly age associated, but not exclusively. Even young people can get osteoporosis as a result of lots of different nutritional deficits or mostly nutritional deficits or congenital abnormalities that affect bone growth. And it's this condition where the bones become fragile and brittle, leading to higher risk of fractures, breaks or cracks. Commonly green stick fractures as well, than in normal bone matrix. And it occurs, so osteoporosis occurs where bones lose minerals, primarily calcium, and that occurs more quickly than the body can replace them, leading to a loss of bone thickness or bone density. And as a result, bones become thinner and less dense, so that even minor bumps or accidents can cause quite significant fractures. Any bone can be affected by osteoporosis, and common sites are hip and spine, wrist, ribs, pelvis, and upper arm. It usually has no signs or symptoms until a patient gets a fracture. So this is why osteoporosis is often called the silent disease. Fractures due to osteoporosis can lead to changes in posture, especially in the older generation, especially when they get fractures in the spine, and they can commonly present with this dowager's hump or a stoop. It is estimated that every 5 to 6 minutes that somebody is admitted to an Australian hospital with an osteoporotic fracture. And it's expected to get even more significant in the future. So what we can do to treat osteoporosis is increase calcium supplements, whether that be dietary or oral mineral supplements, and also replace hormones that are lost after menopause. Okay, so more musculoskeletal or torticollis or wry neck is this abnormal spasm of the neck and usually only affects one side. And this commonly occurs to people when they wake up and they've got this twisted head position that's really painful and it's difficult to straighten out. There's a few different causes. So one of them is congenital, or it happens as a result. It happens in neonates, which is a congenital muscular torticollis. Happens in 1% of neonates, and can be associated, or it's often associated with difficult deliveries, and can also be a precursor for feeding difficulties in babies, and can sometimes is not picked up until 2 to 8 weeks. You can feel a mass in the sternocleidomastoid muscle, and that's as a result of the shortening of the muscle occurring and causing that twisting of the neck. Can be repaired with gentle massage or twisting, sometimes osteo, even on occasion chiropractic can help to treat torticollis. Yeah, so it's the most common presentation of torticollis is trauma. And usually as a result of whiplash injuries after significant accidents. So they're more of a delayed onset, and the patient gets that painful head twisted and bent over. And the way that these conditions are managed is with Valium, essentially, or muscle relaxants in the hospital. We must exclude with the significant neck pains, quinces, which is a peritonsillar abscess, retropharyngeal abscess, which is common in children, but you will also, not always, but you will also usually get signs of fever as well. Any abscess local to the affected area, cervical and vertebral issues. So if you've got a patient with torticollis who's had a significant history of cervical spine injury, keep that in mind. And another concern is that the patient might be experiencing a dystonic reaction from phenothiazines or like metoclopramide. Okay. All right, this is another one that's close to home for me. Adhesive capsulitis or frozen shoulder. This occurs again by repetitive strain injury, and the shoulder becomes painful and stiff, and the shoulder movements become reduced and sometimes completely frozen. And this freezing is thought to be as a result of inflammation and thickening of the shoulder capsule, inhibiting movement. So typical symptoms include pain and stiffness and limitation in the range of movement. And they usually have these three phases. So they have this initial freezing, painful phase, and that can last 2 to 9 months. And it's usually pain as the first symptom. The frozen or stiff adhesive phase typically lasts another 4 to 12 months on top of that. Less painful can sometimes cause a twinge of pain, but it's this point where you can't really move your shoulder particularly well, and the movements that you might have done normally are inhibited. So even things like putting your hand in your back pocket can be inhibited by that freezing, the frozen phase of frozen shoulder. And the phase 3 is the thawing phase, where you start to gradually get your movement back, and that typically lasts anywhere between 5 months and 4 years. Pain is usually absent, can occasionally get a few twinges, but usually not there, and movement will gradually come back whilst you're using it. So people who get frozen shoulder are adults, usually at some stage of their life, they've been doing some sort of repetitive strain injury, particularly where they're lifting weights over their shoulder with their arm extended, i.e. lifting the defibrillator out of the back of the ambulance. Yeah. And it's probably one of those only things that we will talk about where you get this stiffness in the shoulder. That's not a form of arthritis. Treatment is it can be as invasive as steroid injections, but commonly non-steroidal anti-inflammatories and paracetamol for analgesia. And it's one of those things where you just have to wait and see. We will probably see these types of patients in that acute freezing stage where they've got a significant onset of shoulder pain. Okay. Plantar fasciitis is a bugger. It's this common form of recurrent foot pain where you get an inflammation or acute inflammation to that fascia that sits underneath the foot. Patients will be in excruciating pain. They sometimes as a result of bony spurs, which you can see on x-rays, but often is just as a result of tight tendons or tendonitis in the Achilles, causing significant strained plantar fascia, and that's people will get significant pain when they are trying to walk. So treatment is with the podiatrist, and that is usually commonly trying to stretch the fascia out. Stretch the fascia out and stretch out the tendons in order to help reduce the strain on the plantar fascia. And what they will commonly do is put an orthotic or something that helps to mold to the bony prominence of your foot rather than just being quite flat. Anti-inflammatories are recommended, and physio and stretching exercises are also recommended. Carpal tunnel is a neuropathy of the median nerve of the wrist. So the median nerve runs straight underneath that transverse carpal ligament. And so that's the median nerve, innervates half of your ring finger, your middle finger, your pointer, and your thumb. Okay? And you get this significant shooting pain all the way up. And that's as a result of that transverse ligament trapping that nerve underneath, and can cause significant pain. Commonly as a result of overuse of the wrist. So again, I have known quite a few midwives who actually get carpal tunnel as a result of that fine motor function. Mums can get carpal tunnel. And funnily enough, one of those things that pregnant women are more at risk of getting, don't know the exact reason for that, but probably has something to do with hormones, I would imagine. So management of carpal tunnel is pain relief, commonly splinting to stop excessive movement and try and release the nerve from being trapped under there. Sometimes it is surgery as well. And that is used just to cut the ligament at the front there to release the nerve. So differentials, de Quervain synovitis, which is where you get the pain here and it causes pain in the thumb. It's not necessarily carpal tunnel. Arthritis and rheumatoid arthritis. So non-traumatic neck pain. So soft tissue injury, hyperextension of the muscles of the neck, and all these sorts of things will be covered in more detail in CSB337. Disc herniations, whilst traditionally is more traumatic in nature, it can be quite benign as picking things up off the floor, causing a disc herniation. And the disc herniation is commonly of the L5, just because of the way that they're L1, between L1 and 2, and also L4 and 5, will commonly get a disc herniation, just because that is one of the most significant weight-bearing areas of the back in the bigger vertebrae, and they will carry a significant portion of the weight. And if a patient is bent over trying to pick something up, you've got this wedge-shaped cartilage in between L4, L5, and as the pressure is being pushed on here, that cartilage is more likely to pop out the back. Ooh. Pop out the back and cause a disc herniation. So a disc herniation doesn't necessarily mean just the disc, but you've got this pulposa on the inside of the intervertebral disc, and so that can actually pop out, so completely bulge, so that pulposa can actually pop directly out of the intervertebral disc, and can push on spinal nerves, causing significant pain also. Okay. Okay. It's just, spinal disc problems can also lead to sciatica as well, which is where you get that pain shooting down right into this the sciatic pain, and that's usually when you got injury in your back, lower down. The cauda equina contains the nerve roots from L1 to L5 and S1 to S5. And this spinal pathology below the L1 of the vertebral column produces mostly lower motor neuron signs. Excuse me. And it's this neurosurgical emergency, and it's due to compression of nerve roots of the cauda equina below the level of the spinal cord. And a common cause is that, like I spoke to you before, that prolapse of the intervertebral disc. So as the patient is bending over, that wedge-shaped disc will pop out and push straight into the cauda equina and can cause a compression, and you'll need surgery in order to fix it. And the cauda equina is this bunch of nerves here that's not myelinated like up here in the rest of the spinal column. It's this bunch of nerves that is supposed to look like a horse's tail, hence the equina. And it's the cauda because it is still part of the spinal cord. So some symptoms of cauda equina include saddle anesthesia, so numbness in your butt, essentially, onset of bladder dysfunction, onset of fecal incontinence. They will examine you if you've got these symptoms, or if a patient's got these symptoms, they will examine them for perianal and perineal sensory loss, as that's another concern, and this severe progressive neurological onset of symptoms in your legs, like paresthesia and paralysis. Okay, so we spoke a bit about disc herniations. Spondylosis, primarily cervical spondylosis, is a chronic cervical disc degeneration, commonly with a herniation of a disc material, calcification, and osteophytic outgrowth, so where the bone grows into the vertebral column itself, causing impaction of the spinal cord. So so it can cause back pain and simple neck pain, and usually varies in time with activity. It's the most frequent musculoskeletal cause of consultation. So that's neck pain is the second most frequent musculoskeletal cause of consultation in primary care worldwide. It's multifactorial, like back pain, multifactorial, like causing, usually as a result of poor posture, muscle sprain, sporting, and sometimes occupational activities, as well as psychological factors. Cervical spondylosis undoubtedly contributes to this condition, but also may cause radiculopathy due to compression and stretching or angulation of the cervical nerve roots, and myelopathy due to compression of the vertebra and compromised blood supply. Yeah. Okay. Where am I? Myelopathy, and features of myelopathy or cancers in the spine or in the neck, suggestive of myelopathy. They're commonly insidious in progression. You can end up with a gait disturbance, and sometimes you get clumsy hands as a result as well. Loss of sexual function, bladder and bowel function deterioration, often quite a late sign. And you get this electric shock type sensation, or you can do type sensation radiating down the spine, which is called Limited sign. Sensory changes are variable, and you can get the loss of vibration and joint position sense, seen more clearly in the hands and then the feet, these sorts of symptoms. Other alerting features include history of risk factors of osteoporosis, history of recent trauma or fall from a height, and history of neck surgery. History, dizziness when moving the neck and drop attacks, suggestive of vascular disease. So other non-specific neck pain lesions can also cause acute neck pain and neck strain, postural neck ache or whiplash, and some malignancy like primary tumours, secondary deposits, or myeloma infections, even osteomyelitis. Yeah. Okay. And psychogenic neck pain is something that can occur, as well as inflammatory disease or rheumatoid arthritis of the neck can cause neck pain as well. Okay. So back pain is another massive consideration. And we talked a little bit about sciatica before, but it's a name for this syndrome, which is characterized by pain that radiates along the path of the sciatic nerve. The sciatic nerve is the longest nerve in the body, and it's almost as thick as one of your fingers when it comes out of the lower spine, and it travels from your lower body through your hip and your butt, down your butt, and to where it divides into to your leg, where it divides into branches at the knee. And each leg has its very own sciatic nerve. The pain felt from sciatica is felt along the sciatic nerve and can be deep in the butt. And it is quite commonly felt in pregnancy, and pregnant women will complain of this electric shock type sensation that can be felt along the nerve and radiates commonly down both butt cheeks. And the pain can be from mild to incapacitating, where patients are unable to walk. Can be felt when you sneeze, cough, or go to the toilet, or when you're sitting. And it's commonly associated with lower back pain as well. Okay, we talked a little bit about disc herniation. And it's probably one of the most common causes of sciatica and most common causes of back pain or lower back pain as well. And it's where the intravertebral discs bulge or stick out, like we said. Spinal stenosis, where you get this narrowing of the spinal column, and it can cause pressure on the spinal cord, or narrowings of the openings of the spinal cord where the nerves leave the spinal column. And this develops as a person age, and discs become drier and start to shrink up with age. And at the same time, bones and ligaments of the spine swell commonly and grow larger due to arthritis or some other chronic inflammation. It can be genetic, and it can be as a part of birth defects, or it can even onset as a result of infections sometimes. Stenosis can also be caused by arthritis involving the spine. Ankylosing spondylitis is a type of inflammatory arthritis that targets the joints of the spine. It particularly in the sacroiliac joint. So sacroiliac joints, these joints here on either side of the sacral spine. And symptoms include back pain, stiffness, and reduced mobility in the spine. So, and difficulty bending over is common. And so inflammation occurs, and as a result, new bone can grow around the spine in response to the inflammation. And this fusion of the vertebrae that make up the spine can cause pain and significantly reduce mobility. And it's important to commence treatment in early ankylosing spondylitis to reduce of the spine becoming fused, and especially if it's fused in a bent forward or a stooped posture. So scoliosis is the type of sideways twisting of the spine. Cause is usually unknown, and will commonly have surgery to repair, where they put metal rods right up the side of the spinal column. Kyphosis is a result of an extended outward curvature of the spine, and lordosis is an excessive inward curvature of the spine. Gout and pseudogout. So gout is, which we'll cover a little bit more because it's quite a common presentation, is as a result of hyperuremic acid. So excess uric acid build-up in the body. And it's these crystals form in the joints, and joints as a result become inflamed and very painful. And pseudogout is a type of inflammation of the joints caused by deposits of crystals, and it's not urates, it's called calcium pyrophosphate in and around the joints, and it literally means false gout. So it's a similar sort of process, but it's a different crystal that forms in the joints. Okay, so gout. So it was first identified by the Egyptians in 2640 BC. Metatarsal phalangeal gout. So usually gout in that big toe, in that metatarsal there, in that first joint, was recognized by Hippocrates in the 5th century as the unwalkable disease. And I've mentioned the humours before, but there's 4 humours, and it's thought that gout was as a result. There's 4 humours, and when they're balanced, people are thought to be in good health. And the way that gout got its name is the word gout came from the Latin word called gutta, meaning to drop. It referred to what they thought was an excess of one of the humours, which would drop into a joint, particularly that first joint in the big toe, and it causes pain and inflammation. Because gout is known to be caused by rich foods and alcohol, it's referred to as the disease of the kings. At one point in the early 1900s, it was actually seen to raise a person's social status when they actually had gout. And like we said, it's caused by hyperuricemia, so increased urate crystals in and around the joints. It's that metatarsophalangeal joint, which is that joint in the big toe, which is that big pad just underneath the big toe. Can be as a result of, so you can get hyperuricemia as a result of an increased production of urates, and can be as a result of autoimmune conditions and malignancies. Otherwise, it's commonly known to be an increased intake of high purine foods, like liver, kidneys, anchovies, and alcoholism, especially beer, because it's particularly rich in purine. So management is to manage pain, tenderness, warmth, redness and swelling, non-steroidal anti-inflammatories, and allopurinol is a common medication for gout, and it is a purine analog. So gout doesn't necessarily only have to occur in the toes. It can occur in fingers as well, and actually can occur in most joints, but just the smaller joints are most likely to be affected. And this is called a gouty carbuncle, whereas there was so much uric acid collected in the joint that it became infected and inflamed, and therefore became pussy and busted. And this is one of my pictures. Okay. The out-of-hospital management for pretty much everything that we talked about is manage ABCs, quality history taking. I cannot emphasize quality history taking and quality assessment anymore, and it's important to manage the patient's pain. All right, so that's our summary, which basically goes over our objectives, and that's the end of my story. Thanks so much for listening.